welcome to the module of bone tumors, a topic dreaded by a lot of students and for good reason. The reason is, number one, the names of these tumors, they sound familiar. For example, osteochondroma, chondrosarcoma, enchondroma, and they are different. Number two, it is said that bone tumors follow only one rule, and that rule is that they do not follow any rule. That is the big problem of bone tumors. A tumor that starts in the epiphysis can end up in metaphysis. A tumor that starts in the diaphysis can end up in metaphysis. A tumor in metaphysis can go anywhere they like. And there are tumors that can grow anywhere they want in the bone. And this becomes a nightmare for students, particularly preparing for an MCQ-based objective exam, because here on the exam, you have to answer only one option, whether the lesion is epiphyseal, metaphyseal, or diaphyseal. And this makes it very difficult for students to grasp this topic. So this is what I have done. Over the years of my teaching and myself once when I was preparing for these exams, I realized that this was not happening. So the information that is given in these tables are basically to give you an objective approach of answering the MCQ. See, the challenge on the MCQ exam is not the knowledge of theory. I'm sure you will have good knowledge about the theory of the condition. For example, if I tell me about osteosarcoma, you'll probably start like a parrot and tell me everything about osteosarcoma. If I tell me about Ewing sarcoma, you'll probably sit down and tell me everything about Ewing sarcoma for half an hour. Maybe you will know more than I do also. But the point is not that. This is an MCQ-based exam. The point here is to basically make a diagnosis from the differential of options provided to you in the question. And that is what I'm going to help you with. The aim of basically condensing the bone tumors into a certain tables was to make it easy for you to make the diagnosis, trying to distinct it or differentiate it from other conditions that may sound similar or present similarly. Are you following me? So with that, let me start with bone tumors and we'll slowly ease into it. I'll give you my legendary tables that will help you answer these questions without a lot of problem on the exam. So the first thing that we'll do is we'll start with the history of orthopedic oncology. Look at this gentleman over here. He is considered as the father of orthopedic oncology. His name is William Eniging. Okay, so he was the person who basically staged the bone tumors into benign and malignant bone tumors. The way he staged or classified bone tumors was benign. He classified into latent, active, and aggressive bone tumors. And malignant bone tumors, he graded them based on low grade or high grade or any grade with metastasis. So this is the provisional staging classification that he had given. So on what basis did he do this? Please understand that benign bone tumors are tumors that are localized to a particular part of the bone, right? They do not usually metastasize and they're usually encapsulated. On the other hand, a malignant bone tumor is something that will metastasize. That will means spread to other bones or other parts of the body. And they're usually not encapsulated. So this is the broad difference between them. The fine difference between them is this. A latent benign tumor, for example, is something like this. Say this is the capsule. Right? This is the capsule. And this is the tumor that is growing. Since it's so latent, it is so slow growing that the body has ample time to basically surround it with a nice thick capsule, preventing its spread. So please understand that it will have a thick capsule and the lesion will be nicely sitting comfortably inside without spreading too much. So this is something like latent benign tumor. On the other hand, what is an active benign tumor? An active benign tumor is a tumor that is growing but still remains inside the capsule. So this is a tumor that is trying to grow actively, but it is still surrounded by the capsule, albeit the capsule is thin. The capsule is thin because the tumor is growing at a faster pace, relatively faster pace. On the other hand, what is an aggressive benign tumor? An aggressive benign tumor is something that is aggressively growing. It is benign, so it should be encapsulated. So it is encapsulated usually, but because the tumor is aggressively growing, it breaches the capsule and grows beyond it. So these are the broad differences between latent, active, and aggressive benign tumor. Let me give you the examples. Latent benign tumor, the example is non-ossifying fibroma. It will not make sense to you now. It will make sense to you later, but please bear with me for some time. An active benign bone tumor, the example is aneurysmal bone cyst. And an aggressive benign tumor, the example is giant cell tumor. You have to bear with me. Trust me on this. Once we finish the complete module of bone tumors, only then things will make sense to you, right? You have to bear with me. So latent, active, and aggressive benign tumor. Now, malignant bone tumors is staged into low grade, high grade, or any grade with metastasis. Now, low grade malignant bone tumors is further subclassified into intracompartmental and extracompartmental. Now, what do you mean by intracompartmental and extracompartmental? Let me show you this. Say this is your bone, right? If the tumor grows within the bone, it is in one compartment, that is intracompartmental. If the tumor grows beyond the bone and moves into the soft tissue, you would call it extra-compartmental bone tumor. Okay, so low-grade tumor that remains inside the bone is 1A, that is low-grade intracompartmental, and a low-grade malignant bone tumor that grows beyond the bone is 1B, that is low-grade extracompartmental. Similarly, 2A is high-grade intracompartmental, 2B is high-grade extracompartmental. Okay? And any grade, whether it's low or high, if it metastasizes, we call it 3. So this was the staging given by Enneking. Okay, is that clear? Now, we are not interested in Enneking staging anymore because we have something better. We have WHO classification, which has classified bone tumors into tumor-like lesions and then the actual tumors. Okay, this will be very helpful for us to understand the big picture of bone tumors. So what are tumor-like lesions? Tumor-like lesions are lesions that look like tumor but are not tumors. Okay? They look like tumor but they are not tumors. So what are these? You have fibrous cortical defect here, also known as non-ossifying fibroma. Like I said, trust me. Soldier through this module, and only after the end of the module, everything will start making sense to you. Alright, just bear with me. Another example of tumor-like lesion is fibrous dysplasia, and then you have bone cysts. There are two types of bone cysts. There are cysts in the bone, a simple bone cyst and an aneurysmal bone cyst. All of these are tumor-like lesions. They are not tumors, they are tumor-like lesions. Right? Then there will be true tumors that we will discuss in a bit. But before we go there, there is something I want you to understand. There is a lesion known as osteochondroma, which behaves ambiguously. It has features that suggest that it is a tumor, and it has features that suggest that it's not a tumor. Okay? All right, just understand this for now. I'll explain later. The reason they consider it as a tumor is because it can grow and it can become malignant later in life. Can. And the reason they do not consider it a tumor is because usually it stops growing as the skeleton matures, which means that any one point in time it will stop growing. And we know that by definition a tumor should never stop growing, but it does stop growing. That's why it is ambiguous. And we have kept it right here in the middle between tumor-like lesions and the actual tumors. Details I'll talk about later. Right? So let's start with tumor-like lesions, then we will discuss osteochondroma and then move on to the tumors. Now the actual tumors, how has the WHO classified it? WHO has classified it based on the cell or the predominant cell of the tumor. Now what are the types of cells that we are going to discuss here in the bone? We are going to talk about chondrocytes that produce cartilage. We'll talk about osteoblasts that produce osteoid and the bone. And we'll talk about osteoclast that resorb the bone. These are the predominant type of cells that we are going to discuss today. And then there are the miscellaneous category which do not fit into the cell groups that we have talked about. Now, how is this helpful? How is this classification helpful for us? Trust me, it is very helpful, and I'll tell you why. See, if you know the cell of origin or the predominant cell of the tumor, what else do you know about it? Number one, you will know what you will find on the biopsy. Because biopsy is the standard or the gold standard investigation for any kind of tumor. Because if you know what cell it is, then your diagnosis is confirmed. Radiologically, the diagnosis is confusing. But biopsy is never confusing. It's the best investigation available to make the diagnosis for any tumor. Right? So if you know the cell of origin, you will have a diagnosis based on the biopsy. Number two, if you know the cell of origin, you will also know the radiological findings. For example, say it's a cartilaginous tumor. Right? So what will be a cartilaginous tumor like or appear like on X-ray? You see, a cartilage is usually not visible on X-ray because it's lucent, it's hazy, it's radiolucent. So if there is a tumor that is cartilaginous, there will be less density in the bone, right? Suggesting that there is cartilage in place of the bone. And because it's a tumor, there will be some amount of calcification here and there. On the other hand, if it's an osteoblastic tumor, you will know that this tumor will be making abnormal osteoid and bone. So you will see bone being formed in the location of the tumor. And finally, if it's an osteoclastic tumor, what do you imagine it is? Osteoclast, they will resorb the bone, so there will be bone eaten away or bone getting destroyed on X-ray. Just by knowing the cell of origin, you know how it will be on biopsy, you will know how it will be represented on X-ray as well. That is the power of knowing these classifications and tables. Okay? So what are the chondrocytic or chondroblastic benign and malignant tumors? Chondroblastic benign tumors are two: enchondroma, chondroblastoma. So what are you hearing here? The word chondro. The word chondro. So if there is a word chondro, means there is cartilaginous element. So enchondroma, chondroblastoma, these are benign cartilaginous tumors. So you already know how they will appear on X-ray. Malignant variant of cartilaginous tumor is chondrosarcoma. Another hack, wherever there is the word sarcoma, is it benign or malignant? Malignant. Okay? So far so good. Similarly, osteoblastic benign tumors क्या होंगे? What will they be? They will be osteoid, osteoma, osteoblastoma. So the word osteo is there, right? So osteoid, osteoma, osteoblastoma, both of them are benign osteoblastic tumors. What about the malignant osteoblastic tumor? What do you have? You have osteosarcoma. Like I said, sarcoma, malignant. So far so good, right? What about osteoclastic cells? The tumors of the osteoclastic cell type would be osteoclastoma, and osteoclastoma, friends, is unique. It is both benign and malignant. Usually it is benign and aggressive. Very rarely it can become malignant. Less than 5% of the patients who have osteoclastoma, they can show metastasis. So usually it is aggressive benign. Because we read it in the previous classification of staging, right? Latent, active and aggressive. The example of aggressive was giant cell tumor, right? So this is the classical WHO classification. Now there are certain miscellaneous tumors that do not fall into this category, right? What are they? You have two very important ones. One is hemangioma, the other is Ewing sarcoma. Hemangioma is a benign vascular tumor. It's a benign vascular tumor. Okay? Benign vascular tumor occurs in the spine. Whereas Ewing sarcoma is a malignant tumor, number one. It occurs in the bone. Where does it occur? It occurs in the endothelial lining of the bone marrow. It occurs in the endothelial lining of the bone marrow. So truly speaking, it's not a bone tumor. It arises from the endothelial lining of the bone marrow. And the interesting story, we'll discuss about it later. You just need to know this. Alright, so far so good. You've understood this table. You know how to utilize this. Based on the X-ray, you will know that this lesion is a cartilaginous lesion, or this lesion is a bone-forming lesion, or this is a osteoclastic lesion. Right? So powerful. Next. So based on the cell of origin, you know how they will appear on X-ray. If it's a chondrocytic tumor, then there will be lucency in the bone or haziness with some amount of calcification here and there. If there is an osteoblastic tumor, then it will be dense because there will be bone that is formed or sclerosed. If it's an osteoclastic lesion, there will be a bone destruction or bone resorption. Now moving on to the next weapon of your choice, the information of where the tumor occurs in the bone. Because in your exam, there will be a lot of questions that will tell you there is a lesion in the epiphysis of the bone. Which of the following is the diagnosis? All of the following are diaphyseal tumors of the bone, except there is a child who comes to you with a swelling in the middle of the thigh or in the middle of the leg. What do they mean? They mean that there is a swelling or there is a lesion in the diaphysis of the long bone. So you need to know which tumors arise in the epiphysis, which tumors arise in the metaphysis, and which tumors arise in the diaphysis. This will help you segregate the options to come to the diagnosis. I'm telling you, the challenge is to come to the diagnosis. After you come to the diagnosis, theory everybody knows. Theory everybody knows. So here we have a table. To make your life easy, look at this. Diaphysis, metaphysis, epiphysis, right? And what do you have here? You have your growth plate. So this is epiphyseal tumors, metaphyseal tumors, diaphyseal tumors. So what are diaphyseal tumors? You have Ewing sarcoma, osteoid-osteoma, adamantinoma. What are metaphyseal tumors? You have osteosarcoma, osteochondroma, chondrosarcoma, enchondroma. Epiphyseal tumor, giant cell tumor, chondroblastoma. I know it's challenging. I know it's difficult. But Mahuna, I'll make it easy for you. Look at this. For you, if you remember 2 tumors in the epiphysis and 2 tumors in the diaphysis, majority of the questions are in the bag. What are the 2 tumors of the epiphysis? Giant cell tumor and chondroblastoma. Now, how do you differentiate between these two? We'll read the theory, but I'm telling you, theory is not very important. Making the diagnosis is important. So how do you differentiate? Both of them occur in the epiphysis. Right. Chondroblastoma occurs before growth plate fusion, means skeletally immature patient. So look at this. So skeletally immature means growth plate will be visible on X-ray. Lesion in the epiphysis. Think chondroblastoma. Okay, right. Now, giant cell tumor, it occurs after growth plate fusion. Means skeletally mature or immature? Growth plate fusion means skeletally mature individual. Skeletally mature individual, epiphyseal lesion, think giant cell tumor. Okay, so far so good. So giant cell tumor after skeletal maturity usually have soap bubble appearance on X-ray. Chondroblastoma before skeletal maturity has some stippled calcifications on X-ray. We'll talk about that later, right? So far so good. Now, two tumors in the diaphysis. What are those two tumors? I want you to remember. Ewing sarcoma, osteoid osteoma. So Ewing sarcoma and osteoid osteoma. So will you remember this? Will you remember Ewing sarcoma and osteoid osteoma? Just remember this for now. I'll explain everything. Ewing sarcoma, osteoid osteoma, diaphyseal. So 2 in epi, 2 in dia. Everything else will go to meta. You can try to remember the list if you're a champion. But if you can't, it's okay. Please understand this. 2 in the epi, 2 in the diaphysis, everything else will go to the metaphysis. Everything. Osteosarcoma, osteochondroma, aneurysmal bone cyst, simple bone cyst, non-ossified fibrous cortical ricket, chondrosarcoma, and chondroma, whatever. And you also know the reason, because metaphysis is more vascular. Right? Metaphysis is more vascular. Infections occur in metaphysis. Bone tumors occur in the metaphysis. So that is the logic behind it. So 2 epiphyseal, 2 diaphyseal, everything else goes to metaphysis. This way you will be able to differentiate to pick the right answer. Okay, so far so good. This table is also very important. Please try to remember it. The next table I want you to look at is the nature of the tumor. Nature of the tumor. Now the tumor, the lesions can be benign or they can be malignant. Some of them can be benign and aggressive. So benign, I want you to remember osteoid osteoma. Simple bone cyst, aneurysmal bone cyst, are they tumors or tumor-like lesions? They're tumor-like lesions. Obviously they will be benign, so no point talking about it. They're benign. Malignant, anything that ends with the word sarcoma, right? Chondrosarcoma hai, osteosarcoma hai, Ewing sarcoma hai. If you want to know more, adamantinoma and chordoma. These are all malignant tumors. Now there are certain benign tumors that have risk of becoming malignant or are very, very aggressive. So I've called them benign plus plus. Right? They are benign plus plus. So what are these benign plus plus tumors? Please remember this. Giant cell tumor, very, very important. Osteoblastoma, very, very important. Osteochondroma, very, very important. Okay. So osteochondroma, osteoblastoma and giant cell tumor are benign but have a risk of becoming malignant because they are benign plus plus. They are benign but aggressive. Okay. So far so good. Now comes the last but the most important table for your exam. You see, the purpose of these tables I've told you is to make your life easy. As you see the question and pass the information given in the question through these tables, you will realize that the correct answer automatically filters itself and presents to you like a gift on a platter. You will realize this when you start doing the MCQs. Trust me. Now, what is this table? It's a table of age groups. So what are the tumors that occur in the respective or different age groups? The first table is of the age groups here, where I've given you from childhood to elderly population. So 5 to 25 years. So 5 to 25 years. What is the most common tumor that usually occurs in 5 to 25 years? Ewing sarcoma. Okay, so let's talk about the Ewing sarcoma in terms of age of presentation on your exam. Ewing sarcoma occurs in 5 to 25 years of population. Very good. When I say 5 to 25 years of population, how many decades of life are we talking about here? First decade? Yeah. Second decade? Yeah. Third decade of life. So we are talking about 3 decades of life. So Ewing sarcoma can occur in this spectrum of age group 5 to 25. The question is, Ewing sarcoma most commonly occurs in which decade of life? Pay attention. Ewing sarcoma most commonly occurs in which decade of life? The answer is second decade. Okay? It most commonly occurs in second decade of life. But it can also occur in first and the third decade. Are you following me? Are you following? So this is the first MCQ. Second MCQ is, what is the most common malignant tumor of the bone in the first decade of life? What have I asked you? What is the most common malignant bone tumor in the first decade of life? What will be the answer? The answer will be Ewing sarcoma. Are you following me? So listen to me again. What is the most common malignant bone tumor in the first decade of life? The answer is Ewing sarcoma. Okay. Ewing's sarcoma most commonly occurs in which decade of life? Second decade. Two MCQs. Now you've understood how they'll play this game now. Now let's look at this age group. 10 to 20 years. 10 to 20 years. So we are predominantly talking about here first and second decade of life. Okay. So the tumor that we are going to talk about here is osteosarcoma. Osteosarcoma usually occurs in 10 to 20 years of population. Young child, 10 to 20 years of population. What is the most common malignant bone tumor in children? I did not give you any age. I did not say which decade. I just said most common malignant bone tumor in children. What will be your answer? Your answer will be osteosarcoma. Okay? The most common malignant bone tumor in children is osteosarcoma. Osteosarcoma occurs most commonly in which decade? Answer is second decade. Are you following me? Most common malignant bone tumor in children is osteosarcoma. Osteosarcoma most commonly occurs in which decade? Second decade. Okay? Clear? Clear? Very good. So this is how you will answer the questions. Now osteosarcoma occurs again later in life because it is a bimodal tumor. It occurs in two different age groups. First is in children between 10 to 20 years. Second is between 40 to 60 years. This one is known as secondary osteosarcoma. We'll talk about this later. Okay? So primary osteosarcoma between 10 to 20, more common. Secondary osteosarcoma 40 to 60, later in life. And what is the cause here? Why is there secondary osteosarcoma? Primary is de novo. Secondary means there is a primary pathology that is increasing the risk of osteosarcoma manifesting later in life. The most common reason for a secondary osteosarcoma, friends, is Paget's disease. This is an MCQ. There are more reasons. We'll discuss this later. But very importantly, it is Paget's disease. So patient has Paget's disease, his chances of acquiring osteosarcoma later in life is high. Okay? Okay. After that, after 20 years, which age group are we going to talk about? 20 to 40 years. 20 to 40 years means skeletally mature or immature? Skeletally mature. So skeletally mature population. What is the tumor that you usually get between 20 to 40? Think of giant cell tumor. So giant cell tumor will occur in population whose growth plate is fused. Don't mark giant cell tumor if on an X-ray you're looking at the growth plate which is visible. So don't mark GCT for children. Please remember that. Okay. Now 40 to 60 years. One we already know. We know secondary osteosarcoma. Other one is chondrosarcoma. These two tumors usually occurs in 40 to 60 years. So after 60 years, you get all dangerous and malignant tumors. These are, for example, metastasis, multiple myeloma, adamantinoma, choroidoma, all dangerous and dirty tumors, mostly metastasis. Okay, is this table enough for you to basically pick the diagnosis based on the age? The exam questions will be like this. They will give you an age, they will give you a site, they will give you a bone. Based on that, you will be able to answer a lot of MCQs without even knowing the depths of information of each tumor. Right? And this is what I want to remind you. This is an MCQ exam. You should be in a position to differentiate, to make the diagnosis. Alright? Once you've made the diagnosis, friends, after that everybody knows the theory. After that, everybody knows the story. Then you can answer whatever you want. Alright? Now, moving on to the next thing. The next thing is periosteal reactions. This is something that you will read when you are talking about bone tumors. Now, what is periosteal reaction? What is periosteal reaction? It's the reaction of the periosteum. Oh, so self-explanatory. It's a reaction of the periosteum. So this is your bone. We all know that bone is surrounded by periosteum, right? We have read about this in the basics, right? Now, can you tell me what is the function of the periosteum, friends? There are two important functions. One is to provide nutrition in the form of blood. Other is to help the bone grow. So it has osteoprogenitor, osteoblast underneath. It also provides nutrition. Two functions. So for example, there is a tumor or a lesion or an insult or a pathology in the bone. It can be tumor, it can be lesion, it can be infection, it can be any kind of insult to the bone. Whenever there is an insult to the bone, the periosteum surrounding the bone will react because of this insult. And what will its reaction be? Its reaction will be basically to contain the insult. For example, if there is an infection growing or there is a tumor growing, the purpose or the aim of the periosteum is basically to contain the spread of this insult or this pathology. So how will it do it? It will form bone. It will form bone. Because if they form bone, the lesion hopefully might not spread beyond the limits of the bone. That is a periosteal reaction. So now here you need to understand that if the insult or the pathology is a slow growing pathology, the body will have ample time to form a thick or a solid periosteal reaction around it. So for example, if something is very chronic or something is very slow and less aggressive or something is infective, then the body will have a thick or a solid periosteal reaction around it. On the other hand, if there is a tumor or a lesion or a pathology that is very aggressive or rapidly growing at a fast pace, your body will not have enough time to form a periosteal reaction around it. Hence, you will get a thin, lamellated, layered, onion peel-like periosteal reaction around those pathologies. Okay, that is the broad information that I would like to give you at this stage. Later, we'll discuss more. Okay, so that is about your periosteal reactions. A few classical periosteal reactions that you need to remember for your exam is this. A solid periosteal reaction will be seen in osteomyelitis, that is the infection of the bone. Onion peel or lamellated periosteal reaction you will see in Ewing sarcoma. Sunburst appearance and Cordman's triangle, these are the two classical periosteal reactions described for osteosarcoma. These are the periosteal reactions and the tumors associated with them that you should know for your exam. So here I have 3 X-rays basically trying to show you the periosteal reactions that we just talked about. So this is the first X-ray. You don't need to know the pathology just yet. The periosteal reaction that you will observe here, if you look very carefully, it's very difficult I know, is this. Fine layers of periosteal reaction, the lamellated periosteal reaction or the onion peel or onion skin appearance. Seen in, can you tell me? Ewing sarcoma. Very good. Look at this. The second image. There is calcification in the lines like this, like a sun ray or sunburst appearance. This is periosteal reaction seen in osteosarcoma. Very good. And look at this. There is a lesion here in the metaphysis that is growing. And when it grows, it lifts the periosteum with it. And as it lifts the periosteum with it, the bone starts to form under this elevated periosteum. And obviously it will be in the shape of a triangle. And this has been described as Cordman's triangle, a periosteal reaction seen in osteosarcoma. Right. Also, one side note for advanced students, these periosteal reactions, although they have been described for these pathologies, are not pathognomic or exclusive. It can occur in any condition. Okay? So don't be too rigid about it. But mostly, yes, they are restricted to these conditions on your MCQ exams at least. Okay? Right. The next thing that I want to discuss is what are pulsatile bone tumors. Now, pulsatile bone tumors actually pulsate when you go and try to remove them. Right? And if you auscultate them, they will be bruit. So these are tumors that actually pulsate. You just need to know this because they'll ask you a question. Which of the following is a pulsatile bone tumor? All of the following are pulsatile except. So osteosarcoma, the most pulsatile, aneurysmal bone cysts, giant cell tumor, metastasis from renal cell carcinoma, and metastasis from thyroid cancers. For example, follicular carcinoma of thyroid. These are all your pulsatile bone tumors. So you should know this because direct MCQs will come from this. Next, polyostotic lesions. What are polyostotic lesions? Lesions that occur in multiple bones or in multiple parts of the same bone. Okay, these are multicentric lesions, polyostotic lesions. So which lesions are polyostotic? Fibrous dysplasia is, giant cell tumor is, enchondroma is, osteochondroma is. So these you need to know as polyostotic lesions, meaning that if you diagnose a condition like this, you have to look at other places of the body also to find another lesion of the similar kind. Okay? So this basically gives you the general information that you need to know to answer MCQs in bone tumors. Now what we will do is, we'll go into the specific lesions and talk about their theory and details. Now let's start with the first specific condition, fibrous cortical defect or non-ossifying fibroma. Let's see what it means. Fibrous cortical defect. It's in the name. There is a defect in the cortex where the bone is replaced by fibrous tissue. Fibrous cortical defect. Right? Okay. So look at this X-ray over here. What do you see? You see that this is the tibia and this is the femur. Right? And this small thin bone is your fibula. Where is the lesion here? There is a lesion in the epiphysis or metaphysis. There is a lesion in the metaphysis. Is it in the center of the bone or is at the cortex of the bone? It's a eccentric cortical lesion. Please understand what does the word eccentric and centric means. So this is the bone. If the lesion is in the center, you call it centric, obviously. And if the lesion is in the periphery, what do you call it? Eccentric. So there is a lesion that is eccentric. Can you appreciate this? There is an eccentric lesion in the cortex. And how does it appear on X-ray? Is it lucent or dense? Obviously, it is lucent. So what is it? It's basically fibrous cortical defect. There is a cortical defect in the bone where the bone is replaced by fibrous tissue. The other name for it is non-ossifying fibroma because fibrous tissue. It is an eccentric lesion, like I said, and the cortex is replaced by fibrous tissue. Can you see this? Now, I'm showing you the series of X-rays over here, where on the first X-ray it is like this, second it's slightly decreased, third it's almost gone. It is self-resolving. It is a very common condition. It is a very common condition. Most of you have it, but it's asymptomatic. And we don't usually diagnose it. It's usually an incidental finding. It's self-resolving and there is no complaints. It is the most common lesion of the bone. Please be very careful. I said lesion. I did not say tumor. It is the most common lesion of the bone. It can occur in a lot of people. It usually occurs in the first decade of life. And where does it occur? Epi, meta or dia? It's not the 2 of the epi. It's not the 2 of the dia. So it's usually metaphyseal. Okay, see, now the tables are starting to make sense and add value. What is the most common location? Femur. See, most of the tumors, they usually occur around the knee. So distal femur, proximal tibia or femur tibia, that's how it will be. Okay, so this is your non-ossifying fibroma or fibrous cortical defect. Look at this X-ray. Can you look at this and tell me what this is? This bone is tibia. Very good. This is fibula. Very good. This is talus. Very good. Now cortex of the tibia, there is a fibrous tissue which is eccentric. This is your non-ossifying fibroma or fibrous cortical defect. Now in the same theme, the next condition we are talking about is fibrous dysplasia. What does the name mean? There is a dysplasia in the bone where the bone tissue is replaced by fibrous tissue. Essentially the same thing. In fact, it is. The bigger variant of fibrous cortical defect is fibrous dysplasia. Okay, essentially the same thing, but it's on a larger volume. It's basically a developmental anomaly of the bone because it's not a tumor. So while developing the bone, instead of the bone tissue growing, there is fibrous tissue growing because it has been displaced. Right? It has been replaced by fibrous tissue. The bone tissue is replaced by fibrous tissue. That is what happens. So look at these two X-rays here. This is the X-ray of the proximal femur. Proximal femur. And this is the X-ray of humerus. What are you noticing here? There is lucencies here in the proximal femur and there is lucency throughout the humerus. So bone tissue is replaced by fibrous tissue. This is your fibrous dysplasia. There are two variants of this that are very important. Monoostotic means affecting one bone or one part of the bone. Polyostotic, multiple bones or multiple parts of the same bone. Monoostotic is the most common type. It usually occurs in the femur. Okay? It usually occurs in the femur. Now, what happens here? The bone tissue is replaced by fibrous tissue. So, how will it appear on X-ray? What will be the clinical features? So, on X-ray, the bone tissue will be replaced by fibrous tissue. So, there will be lucency or haziness. Classically, lucency and haziness. Now, the surrounding bone of this lucency is haziness will be dense, will be relatively dense. And this will give you an appearance of a dense ring around lucency or haziness. This has been described as Rind sign. And this lucency and haziness has been described as ground glass or hazy appearance. So centrally there will be ground glass or hazy appearance surrounded by a dense sclerotic rim, that is Rind sign. Those are the radiological features. On biopsy, what will you find? Classically, the word is Chinese letter pattern appearance. Okay, direct MCQ. Chinese letter pattern appearance is seen in fibrous dysplasia. Now, what will be the problem in the patient? The problem will be wherever there is a lesion in the bone, classically the patients will complain of pain. Please understand this is general finding. Patient will complain of pain. In fact, any pathology in the bone, any pathology, tumor, lesion, infection, trauma, pain. In orthopedics, the most common complaint is pain. Okay, it's pain. Now, so patient will come to you with a pain. Initially, you will not notice anything. But later on, there will be a ground glass or hazy appearance in the proximal femur. Now, as the disease progresses, the fibrous dysplasia keeps on progressing and makes the bone weak or strong? Weak. Now, the patient puts weight on this weak bone. So, what happens? The bone will start to bend or break. So, as this bone bends, the proximal femur bends in this classical pattern or shape. which has been described as shepherd-crook deformity. For the people who don't know what shepherd-crook is, it's a stick that is held by the shepherds to control their herd or sheep. So this is the stick. So it looks like this. So proximal femur looks like this. So shepherd-crook deformity. This is the deformity that will be seen in the proximal femur. So that is all about fibrous dysplasia, how it appears on X-ray, what is the pathology, and what is the biopsy finding. Okay, now the syndromes that are associated with fibrous dysplasia, they are asked on your exam. Two syndromes. First, McCune-Albright syndrome. Second is Mazabrod syndrome. We'll discuss this. What is McCune-Albright syndrome? McCune-Albright syndrome is basically 3 P's. What is the first P? It's a polyostotic fibrous dysplasia. So patient has polyostotic fibrous dysplasia. Okay. Second P is pigmentation. The patient will have pigmentation on the skin. What type of pigmentation? Café au lait spots, which are different from the café au lait spots that you see in neurofibromatosis. They are different. How are they different? Here the café au lait spots are irregular, whereas in neurofibromatosis they are smooth. Okay. The third P of McCune-Albright syndrome is precocious puberty. So pigmentation, precocious puberty, and polyostotic fibrous dysplasia. A patient presents to you with these 3 P's. He has McCune-Albright syndrome. Okay. What is Mazabrod syndrome? Mazabrod syndrome, patient has polyostotic fibrous dysplasia as well as intramural or muscular myxomas. This is what you need to know for your exam. Now moving on to bone cysts. Very, very important for your exam. There are 2 important types of cysts that you should know. Again, we are still in lesions. There is the simple bone cyst and an aneurysmal bone cyst. Okay. We need to know them in difference because they're almost the same. So we need to know what are the differences, because once you know the differences, then you will be able to make the diagnosis. So the strategy is how to differentiate. All right. Now, simple bone cyst, also known as unicameral bone cyst, because it's a uni means single cameral cavity. Aneurysmal bone cyst is a multiloculated cyst. Look at this. Simple bone cyst is unilocular. Aneurysmal bone cyst is multiloculated. Are you understanding what is the difference? What is a unilocular and a multilocular cyst? A unilocular cyst is a single cyst. A multilocular cyst is a multiloculated. It has multiple locules and they have septations to differentiate. This is a symmetrical expansion and this is an asymmetrical expansile cyst which shows ballooning. So what are these terms? So these terms are very simple. A centric cyst is usually in the center, I've told you. An eccentric cyst is at the edge and it is expanding. How is it expanding? The vertical length will be more than horizontal length. Okay, it will be expanding like a balloon. Balloon has more vertical length than horizontal length. Okay, so ballooning will be seen. So eccentric, expansile and ballooning will be seen in aneurysmal bone cyst. This will be centric and this will be eccentric. Are you able to differentiate so far? Okay. Both of them occur in the metaphysis. Both of them occur in younger population. So these are the similarities. Now, another important difference. Usually I told you lesions and tumors in the bone occur around the knee. But there is an exception to these things. So you have to remember those exceptions because MCQs will come. Proximal humerus is the most common location for simple bone cyst. Okay? And around the knee is your aneurysmal bone cyst, distal femur or proximal tibia. So all of them are metaphyseal. All of them occur in younger population. So growth plate will be open or closed? It will be open. Proximal humerus is usually simple bone cyst. Around the knee is usually aneurysmal bone cyst. Now these cavities, what are they filled with? Clear or straw-colored fluid for simple bone cyst and blood, as the name suggests, for aneurysmal bone cyst. So far so good. I'll show you the x-rays. I'll show you all the findings. Just bear with me, understand what I'm talking about, and then everything will make sense to you. So how do you treat this simple bone cyst? Simple bone cysts are usually self-limiting and self-resolving. So most of the times you don't have to do anything. But if at all the patient complains to you of pain or there is a pathological fracture, then you will have to intervene. Okay. So how do you intervene? You can aspirate the contents of the cyst and then you can inject either sclerosants or steroids. You can inject it with sclerosants or steroids. So basically close the cavity. So inject, aspirate and then inject. That is what you can do. Or you can do a simple excision followed by curettage and then fill the cavity with autologous bone graft. So excise and curate the cavity and fill the cavity with bone graft. That is what is required for simple bone cyst. Ranging from doing nothing to aspirating and injecting sclerosant and steroids or doing an excision with bone grafting. But the treatment for aneurysmal bone cyst is important, hence MCQs. What is the treatment? It is extended curettage. Now, what is this extended curettage, friends? Extended curettage means, for example, there is a lesion in the bone. So what do? You first go in and you remove the lesion. Okay? You excise it. After you've excised it, what do? You basically scrape the cavity, making sure that you remove every last cell, because you don't want the chances of recurrence. So you're excising and you're curating. You're curating the cavity to remove the contents of the cell so that there should be no residual cell. And after doing the curette, extending the curettage by putting something in the cavity that will kill any residual cell that could have been left after the curettage. What will you pour inside to kill those cells that can cause recurrence? You can pour in liquid nitrogen or phenol or fill the cavity with bone cement, because the bone cement, as it sets, start to heat, and because of this heat can kill the cells that can cause the lesion. Okay, so that is extending the curettage process. So what are the substances that you use to extend the curettage process? Liquid nitrogen, phenol or bone cement. Which substance minimizes the risk of recurrence? Best is liquid nitrogen. If you pour in the liquid nitrogen, you minimize the chance of recurrence. But it is challenging, it's difficult. On a surgical table, you pour in liquid nitrogen, there is chance of contamination, liquid nitrogen going somewhere else and causing destruction. Okay, liquid nitrogen, you need to know, is used for extended curettage. Now please remember this extended curettage, very, very important, because there is one more condition that we will discuss that requires this kind of treatment. So aneurysmal bone cyst, extended curettage. Okay, so this was the theory. Now let's look at the radiology of it to understand better. Now look at this X-ray and tell me what it looks like. This is an X-ray of which part of your body? Proximal humerus, right? Now once you know that, look at the various parts of the bone. This is your epiphysis, this is the metaphysis, and this is the diaphysis. Okay. Where is the lesion? The lesion is in the metaphysis. What about the growth plate? Is it open or closed? It looks like it's open, so skeletally immature patient. Now look at the lesion. Can you describe the lesion? It is a lucent cystic lesion in the metaphysis. It is a single solitary centric cyst in the proximal humerus. What do you think it is? It is your simple bone cyst. That's how easy it is if you know how to pick it up on X-ray. Now look at this. Again, this is an X-ray of the proximal humerus. Epiphysis is absolutely normal. Growth plate is open. Diaphysis is normal. Lesion is in the metaphysis. Single solitary centric cyst. Again, look at this X-ray. Proximal humerus. Epiphysis is normal. Growth plate is patent. There is a single solitary centric cyst. Diaphysis is normal. Lesion is in the metaphysis. Okay, so far so good. Now there are two radiological signs that are asked on your exam. Fallen fragment or fallen leaf sign. Another is a trapdoor sign. Let's try to appreciate them. What are these? Look at this lesion over here. This is the same simple bone cyst X-ray that I just showed you. Here what is happening is that a part of the cortex is breaking. So this is the piece of the cortex that has broken away. And because it is a single solitary centric cyst, this part of the broken cortex will slowly sink down to the base of the cavity because of the gravity. So this is known as a fallen fragment or fallen leaf sign seen in simple bone cyst. Okay, so this is the first thing you should remember. The second radiological finding you should remember is trapdoor sign. What is a trapdoor? It's a trapdoor. It's a hidden door on the floor so that you can go down the stairs underneath it. This is the image there. So it's there is a hinge-like door on the floor. Here what is happening is single solitary centric cyst, and you're noticing that the cortex is broken here, but it's still attached to the periosteum and hinging on it. It's like a trapdoor. That's how it got its name. That's all. These are your simple bone cyst radiological findings. Now look at this image and tell me, what do you see? Again, step by step, what do you notice? There is a lesion in the proximal tibia. Epiphysis is normal. Growth plate is open, means immature skeleton. Lesion is in the metaphysis. Diaphysis is absolutely normal. Now can you describe the lesion in the metaphysis? It's a multiloculated cyst. Yes, it is a multiloculated cyst. So what is this? This is your aneurysmal bone cyst. So what are you learning here? How do you pick up these findings on X-ray? Step by step. First, you need to identify the part of the body. Knee hai, proximal humerus hai, elbow hai, hip hai. That's what you need to do. Second, which part of the bone is affected? Is it epi, meta or dia? Or is it epi-meta or meta-dia, dia-meta? Okay, that you have to do. Third thing is look for skeletal maturity. Is the growth plate visible or not? Because you know there are certain lesions that occur after skeletal maturity and certain before it. Like for example, GCT will always occur after skeletal maturity on your exam. Okay? Then look for the description of the lesion. How is it? Is it centric? Is it multiloculated? Is it unilocular? Is it eccentric? Okay? Finally, the other classical findings like trapdoor sign or fallen leaf sign or fluid in fluid level, all these things that you can look for to help you make the radiological diagnosis. Okay, and obviously you have to correlate it with the clinical history. ठीक है ना? Right, this is how you work it out. Now the next thing that I want you to know is there are certain lesions that give you multiple fluid levels. Multiple fluids levels. So obviously when there are multiple fluid levels in a lesion, which means that there are multiple cavities. So multiloculated lesions. So what are these lesions that have multiple loculations and will give you multiple fluid levels on MRI? Direct MCQ. Obviously one is aneurysmal bone cyst. Another is giant cell tumor and a variant of osteosarcoma known as telangiectatic osteosarcoma. These all will give you fluid levels on the bone. Okay. Finally, to make your life a little easy when it comes to cysts and lesions in the bone, this is a table that will help you make a diagnosis on your exam. So look for these cysts and where are they located. If the cyst is centric, the usual differential is between these three. If the cyst is centric, the usual differential is between a simple bone cyst, enchondroma or Brodie's abscess. Don't worry about it. At the end of this topic, you will know what is enchondroma as well. But once you read infections, you will know Brodie's abscess. Okay? Because in the exam, the questions will not be telling you that this question is coming from infections or bone tumors. It will be a clinical vignette and you will have to make the diagnosis. Okay? So remember, a centric cyst, think of these. And if it's an eccentric cyst, think of this: giant cell tumor, aneurysmal bone cyst, or fibrous cortical defect. Okay? This is just to help you make a differential diagnosis on your exam. Now the next topic we are discussing is osteochondroma. The one which was between tumor-like lesions and the actual tumor. Okay, so that orphan lesion that was sitting between the two. This is the most common benign bone tumor. Please remember this very, very important question. It is the most common benign bone tumor. But please remember, it is not an actual tumor because it stops growing after skeletal maturity. And since it stops growing after skeletal maturity, it cannot be a true tumor. That's why there is another MCQ in the market. What is that? What is the most common true benign bone tumor? The answer for that is osteoid osteoma, which we will be discussing later. So be careful on the exam. The most common benign bone tumor is osteochondroma. Most common true benign bone tumor is osteoid osteoma. But what is the most common lesion of the bone? The answer is fibrous cortical defect. All right. Now, so what is this osteochondroma? Why does it occur? It is basically a developmental malformation of the growth plate. Let me explain. If you go back to your basics, I've told you that the bone between epi and meta has a growth plate. And you recall what are the layers of the growth plate from your basics? The germinal, the proliferative, hypertrophic, layer of calcification, layer of ossification. What was the significance of knowing these layers? The significance was this was the direction of the growth of the bone. Right? This was the direction of the growth of the bone. Now, in osteochondroma, there is a developmental anomaly of the growth plate where the bone, instead of growing directly, vertically upward, starts to grow towards the side. So, what is the first thing that you will notice? That there will be a lesion growing towards the side, towards the joint or away from the joint? Obviously, away from the joint. Lesion always growing away from the joint line. First, very important part. Second point is that since it's a normal bone just growing in abnormal direction, the architecture of this growth will be exactly the same as the normal bone. The cortical alignment will be maintained, the medullary alignment and the architecture will be maintained. Okay, these are the two important things I wanted to remember about osteochondroma. I'll explain more in detail. So it's a developmental malformation of the growth plate. It can be both pedunculated or sessile. The stalk always grows away from the joint line like I described. So look at this lesion here. It's in the metaphysis and there is a lesion that is growing away from the joint. Okay. It has a bony pedicle and a cartilaginous cap. This is very, very interesting. Cartilaginous cap is usually less than 2 centimeter. Now, why is this important? See, cartilage is not picked up on X-ray, right? So, when a patient comes to you with this osteochondroma, he will tell you that he's noticing a swelling around the joint because the growth plates are usually located around the joints only. Swelling around the joint, particularly with knee joint. Okay, a swelling around the joint. You palpate it. What will you notice? You feel that it's a large swelling, it's a bony swelling that's large. You send the patient for X-ray. And what will you notice on X-ray? You will notice a small lesion on X-ray because you're only looking at the bony pedicle and not seeing the cartilaginous cap. So there will be this clinico-radiological discrepancy in osteochondroma that will help you make the diagnosis. Okay. Another thing that you should know is that it will be seen in a growing skeleton. And once the skeleton is matured, the growth will stop. That is why it is not a true tumor. Okay, so these two things I want you to understand and remember. So stops growing after skeletal maturity, usually occurs around the knee. Most common site is the distal femur. So far so good. Are you able to appreciate this? Now, like I said, the architecture matches the normal bone. So this is a CT scan image. And what are you seeing on the CT scan? The cortex matches the cortex and the medulla matches the medulla. It's an absolutely normal bone just growing in an aberrant direction because of a developmental malformation. Now, can you imagine what will be the clinical features? A growth around the joint, usually asymptomatic, grows with skeletal maturity and fuses once the skeletal maturity is achieved. What will be the usual complaints? The complaints will be a swelling and the pain that that swelling causes. Usually asymptomatic, grows with the skeleton and stops with skeletal maturity. Causes of pain. It causes pain. So what are the causes of pain? They'll ask you on MCQ. There are 4 important causes of pain because of this growth. First, it will compress the bursa in front of it and cause bursitis. This is the most common cause of pain. Second, it can compress the nerve and this may present you with pain. Third, it can fracture as the patient is careless or walking or jumping or fighting or doing whatever. It can fracture and all of these can cause pain. Lastly, it can rarely transform into a chondrosarcoma, which will also present as pain. Are you following? So it can transform into a chondrosarcoma. Very rarely, albeit, but it can. That is why it is sitting in the orphan category. It has characteristics that does not make it a tumor, but it has a potential to become malignant. So it has characteristics of a tumor. Which tumor will it become? Chondrosarcoma. Is that clear? Now, the next point I want you to know is, what are the features that you will notice in a patient of osteochondroma whose benign osteochondroma has become malignant chondrosarcoma? The first and the most important is that it continues to grow even after skeletal maturity, because we have just discussed normally it should stop growing. If it continues to grow even after skeletal maturity, you should suspect that this benign osteochondroma has become malignant chondrosarcoma. Second, the cartilaginous cap now will be more than 2 centimeters and it will usually be heavily calcified, making it visible on X-ray. Look at this. Cartilaginous cap is more than 2 centimeters and it is heavily calcified on X-ray. These are the features that are suggestive of this benign osteochondroma becoming malignant chondrosarcoma. Now tell me, is pain a feature that will tell you that this benign osteochondroma has become malignant chondrosarcoma? Yes, but it's not very specific because pain can occur because of bursitis, fracture or nerve compression. Right? So what is more important? Thickness of cartilaginous cap, persistence of growth even after skeletal maturity, and heavy calcification of the cartilaginous cap. These things you should keep in mind to make the diagnosis. And once it has become chondrosarcoma, you will have to treat it like chondrosarcoma. Okay. Now coming back to the treatment of osteochondroma, how will you treat this condition? The treatment of this condition is actually initially wait and watch, because it will continue to grow even after it will continue to grow as the skeleton is maturing, but it will stop growing. The problem is, if you remove it before skeletal maturity, there will be recurrence. So wait till skeletal maturity, and after skeletal maturity, go for extra periosteal excision. So good counseling of the patient is required. Sit him down, sit his parents down, tell them, don't worry about it. It's a benign condition. It will stop growing. And once it stops growing, I will remove it. Okay. And be watchful of these things and report to me if these things happen. Like it starts to grow aggressively or rapidly or the thickness increases. Okay. That is what you will tell them. Now, There is a variant of this osteochondroma that is inherited. That is known as hereditary multiple exotosis. You see, the other name for osteochondroma was exotosis. Here the patient has hereditary multiple osteochondromatosis or hereditary multiple exotosis. Matlab, this patient has multiple exotosis or multiple osteochondromas. The term for this is diaphyseal achalasis, and be very careful, this is a misnomer because we all know osteochondroma occurs in the metaphysis. The term is diaphyseal achalasis. So what happens here? This is an autosomal dominant inherited condition, which is an MCQ, and occurs because of a mutation in EXT1 and 2 genes. And because of this mutation, the patient will have multiple osteochondromas. Look at this X-ray. One osteochondroma here, another 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 osteochondroma, multiple osteochondromas. So everywhere around the joints, what will you notice? Swellings. You will notice swellings. This is condition known as hereditary multiple exotosis or multiple osteochondromatosis diaphyseal achalasis. That's all you need to know about this condition. Okay? Now let's start with the actual tumors based on the cell of origin. Chondrocytes, then osteoblasts, then osteoclast. In chondrocytes, the tumors that I told you will talk about is enchondroma and chondroblastoma. Malignant will be chondrosarcoma. So let's say what is chondroma. Chondro means cartilage. Oma is swelling. So these are the tumors of the hyaline cartilage. There are many types, but we are more interested in enchondroma. What is enchondroma? It is a chondroma arising from the medullary cavity. Ecchondroma will be a cartilaginous tumor arising from the periphery, outside. But we are interested in enchondroma. Okay. So how will it appear on X-ray? Because it's a cartilaginous lesion, we all know that will be a lucent or hazy lesion in the bone. And because it's a tumor, there will be some amount of calcification here and there. So it's a cartilaginous lesion with some amount of calcification here and there. The radiologists have used terms to describe that calcification known as popcorn calcification, ring and arc calcification, or O-ring sign, which you should be familiar with. Okay? So it looks like popcorn. Can you look at this? Popcorn calcification, ring or arc calcification, O-ring sign. The two conditions in orthopedics that you should remember are the tumors of cartilage, chondromas, chondrosarcomas. The other tumors that you will read in general surgery are pulmonary hematomas and fibroadenomas of the breast. They will also show you popcorn calcification. Now let's start talking about enchondroma. We already know so much about it. What do we know? We know that it is a cartilaginous tumor. So how will it appear? Lucent or hazy with some calcification here and there. Second thing, what do we know? Is it epi, meta, or diaphyseal? It is a metaphyseal tumor, right? We already know these two very, very important things. It is the most common tumor of bones of hand and feet. Very, very important. If they ask you what is the most common bone tumor of hand or feet, the answer is enchondroma. But be very careful here. If they ask you what is the most common tumor of the hand, without mentioning the word bone, then you should mark squamous cell carcinoma. Like we discussed, it is metaphyseal. Alright? Metaphyseal. How will it appear on X-ray? Lucent or hazy with some calcification here and there. What is the treatment? Excision curettage with bone grafting. So look at this very carefully. These are your metacarpals, right? And what do you notice? There is a lucent or a hazy lesion here in the metaphysis. Let me zoom it for you. Again, metacarpal, epiphysis, metaphysis has lucency or haziness. Metaphysis has lucency or haziness. Simple for your exam. There is a lesion in the phalanges or the metacarpal. Think of enchondroma. Okay, that is all. One important MCQ you should know is the differential diagnosis of this swelling in the metacarpals. Spina ventosa. What is spina ventosa? It is a tuberculosis of the phalanges of the finger. Here also the same thing happen. The phalanges will swell up. That is known as spina ventosa. So it might confuse you between enchondroma and spina ventosa. So keep that in mind. That's a differential diagnosis. Sometimes they ask you on the exam. So these are the findings of enchondroma. This is how they will appear on X-ray. So most common bone tumor of the hand, most common tumor of the hand. Be careful. Now, there are syndromes associated with enchondroma, just like there was a syndrome associated with osteochondroma, like diaphyseal achalasis. What is these syndromes? Ollier syndrome and Maffucci syndrome. What happens here? Now, unlike hereditary multiple exotosis, this is a sporadic condition. That was for autosomal dominant. Here what happens? The patient has multiple enchondromas in the bones. As evident by this X-ray, look at the phalanges and the metacarpals here. Multiple cartilaginous lesions, right? So multiple enchondromas. In Olier's, there is only one problem, that is multiple enchondromas. Whereas in Maffucci syndrome, there are M for Maffucci, M for many problems. What are those many problems? The first is multiple enchondromas. Second is hemangiomas, lymphangiomas, and there is a 100% risk of enchondroma becoming chondrosarcoma. So please understand this. Maffucci and Olier's, which has more risk of malignant transformation? Maffucci, because it has many things, not just multiple enchondromas. Okay, clear hai? This is what you need to know. This is a X-ray of a patient who has multiple enchondromatosis, and this is a patient who has hemangiomas. So this is Maffucci or Olier's? This is Maffucci syndrome. Now moving on to the next cartilaginous tumor, that is chondroblastoma. What do we already know about chondroblastoma? We know that it's a cartilaginous tumor, so it will be lucent, hazy with some calcification here and there. Second, it occurs in the epiphysis. Before or after growth plate fusion? Before growth plate fusion. Two very important things we already know, right? And this will help you make the diagnosis. So it's an epiphyseal tumor occurring before skeletal maturity. So look at this X-ray clearly. So this is an X-ray of the knee joint, femur, tibia. Growth plate is open or closed? Open, right? And there is a lesion here in the epiphysis of the distal femur. Lucent lesion. What is it? It is your chondroblastoma. See, the gentleman who described chondroblastoma was Codman's. So we also call it Codman's tumor. Very, very important point. Why? Because you will get confused here. Because you have read Codman's triangle. Where have you read Codman's triangle? In osteosarcoma. And that is a periosteal reaction seen in osteosarcoma. So please don't get that confused with Codman's tumor. This is the name given to this tumor. This is not a periosteal reaction. Okay, where does it occur most commonly? Proximal, just around the knee and proximal humerus. So around the knee, that is distal femur and proximal tibia and proximal humerus. X-ray, lucent haziness with some stippled or punctate calcifications here and there. Treatment, excision, curettage, followed by bone grafting. These are the things that you already know. What is an MCQ that is frequently asked in chondroblastoma? First, very important, the name, Codman's tumor. Second, the biopsy finding. What is the biopsy finding? Chicken wire calcification. Very, very important. What is this chicken wire? Chicken wire is the fence, the wire fence that we keep around the chicken so that they should not escape. What is their shape? It's something like this. So the calcification on biopsy is like the chicken wire, so we call it chicken wire calcification. Chinese letter pattern appearance was seen in fibrous dysplasia. Chicken wire calcification is seen in chondroblastoma. Now, once we are done with the benign chondroblastic tumors, let's move on to the benign osteoblastic tumor. What do we have to read here? Osteoid osteoma and osteoblastoma. So what is osteoid osteoma? What do we already know about osteoid osteoma? We know that it is a diaphyseal tumor, right? And we know that it's a bone-forming tumor, right? So there will be sclerosis and density somewhere in the lesion. Let's find out. It is the most common true benign bone tumor. Because what is the most common benign bone tumor? Osteochondroma. And this is the most common true benign bone tumor. Usually occurs in the children, in the diaphysis and femur. Lesion is eccentric or cortical. What is the problem here? The story here is very significant. This will be a child, right? Comes to you with pain in the middle of the thigh or the middle of the leg, suggesting diaphyseal involvement. And this pain is classically seen in the night, which is relieved classically with aspirin or salicylate. Very, very important. In fact, the relief of pain by using aspirin or salicylate is so classical that it is diagnostic of osteoid osteoma. It is diagnostic of osteoid osteoma. And please remember that. So what is this osteoid osteoma? Osteoid osteoma, it's a benign osteoblastic tumor where there is an abnormal osteoid surrounded by osteoma. So osteoid, if you recall from the basics, is basically the bone without the mineral, so it will be lucent. So on the X-ray, what will you notice? That there is a cortical lesion. So this is the bone. Here there will be a lesion, a cortical lesion, which is centrally osteoid. Osteoid is bone without the mineral, so central nidus will be lucent. lucent, and it's usually less than 2 centimeter in size, the central nidus, which is surrounded by a dense sclerotic rim. So you're noticing the dense sclerotic rim around the central lucent nidus. Now this central lucent nidus produces prostaglandins that causes the pain, and this pain can be relieved by drugs that inhibit the prostaglandins, like your NSAIDs. Right? So far so good, you've understood? So this is what your osteoid is. Very importantly, you have to learn how to diagnose this on X-ray. So look at this X-ray. This is a lesion here in the diaphysis of the bone. It's in the cortex. There is a central lucent nidus surrounded by dense sclerotic rim. This is your osteoid. Again, look at this. A cortical lesion, central lucent nidus surrounded by a dense sclerotic rim in the diaphysis, particularly of the femur. Again, diaphysis of the femur, central lucent nidus, dense sclerotic rim. The nidus is less than 2 centimeter in size. Patient's pain is in the night, which is relieved with aspirin. This is osteoid. Now, why is it important to know this? Because there is another condition that we have to discuss, osteoblastoma, which is exactly the same as osteoid with a few important differences. What are these differences? Number one, the central nidus of osteoblastoma is more than 2 centimeter in size. First point. Second point is that osteoid usually occurs in the long bones like femur and tibia, whereas osteoblastoma usually occurs in the spine. The pain of osteoblastoma will not be relieved with aspirin. And last and the most important one, that there is a risk of malignant transformation in osteoblastoma, which is not in osteoid. Osteoid is the most common true benign bone tumor and has no risk of becoming malignant. So even if you do not treat osteoid, which you will read in the treatment now, there is nothing to worry about. Whereas osteoblastoma, there is always a risk of malignant transformation into osteosarcoma. That is why the treatment of osteoblastoma will always be excision. Okay? So look at this CT scan image where I'm showing you the spine and there is a lesion in the spine. This is your osteoblastoma. With that principle, what will be the treatment? The treatment of osteoid very simple, NSAIDs. If the patient is responding to NSAIDs, most of the time your treatment is complete. There is nothing else to do. If the patient is responding, there is nothing that you need to do. If he's not responding or he doesn't want to use medications for a longer time, then you can go and surgically remove it. There are various options. You can go for an excision curettage. You can use a radio frequency ablation, particularly in the superficial bones like tibia, particularly in the superficial bones, or you can use MR guided focused ultrasound to ablate the lesion. All right, you can ablate the lesion. But for osteoblastoma, you'll always have to go for excision because there is always a risk of malignant transformation. Now coming to osteoclastic tumor, the big daddy of all the tumors for your exam. If there is one tumor that you should read and go to the exam, that is osteoclastoma. Or in other words, if you do not read osteoclastoma, do not go to the exam. Because in my experience, almost every exam has a question from osteoclastoma. It's a very, very important lesion that you should know, or the tumor that you should know for your exam. Giant cell tumor, also known as osteoclastoma. Alright, so what is it? What do we already know about it? We know that it's an epiphyseal tumor, occurring before or after growth plate fusion, after growth plate fusion. What else do we know? We know that here, osteoclasts are basically destroying the bone, so there will be lucency and lysis or destruction of the bone. Right? Where does it occur most commonly? Usually around the knee. Okay, that much we know. So let's look at it. It's a locally aggressive lesion starting in the epiphysis, moving into the metaphysis. It usually occurs more in females than males. So for the first time, I'm telling you the sexual predilection of this condition. Yes, GCT, G for G, G for girls. G for GCT, G for girls, more common in females. Occurs after skeletal maturity, and what is the most common location? Around the knee, that is distal femur, followed by proximal tibia, followed by distal of the radius. But please be careful, here there is an MCQ. What is the most common tumor of the distal end of the radius? The answer is GCT. In fact, it is so classical for distal end of the radius that if on the exam they show you a lesion at the distal end of the radius and you are unable to identify what it is because you have not attended my class, you can safely mark GCT and majority of the times your answer will be correct. Okay? Sometimes there are classical presentations that you can pick up on exam just by knowing what they are expecting of you. For example, if they show you an X-ray of a wrist of a child, you know that they are trying to show you rickets. For example, they'll show you a fracture of the distal of the radius. Most of the times they're trying to show you Colles fracture. Similarly, if they show you a lesion at the distal of the radius, most of the times they're showing you giant cell tumor. That's how classical it is. But at the same time, you should remember what is the most common location of GCT, that is distal femur followed by proximal tibia followed by distal end of the radius. Okay? Now clinically, what will be the presentation? There will be a swelling, and because the osteoclasts are resorbing the bone, there will be a thin cortex there, swelling with a thin cortex. So as the clinician presses on this swelling, the cortex breaks and gives you the eggshell crackling feeling. The cortex crumbles under your pressure and gives you your eggshell crackling appearance. Radiologically, this destruction is described as soap bubble appearance. So look at this X-ray now. What is this X-ray showing you? Step by step, work it out. Which part of the body are they showing you? They're showing you the wrist, right? Wrist. Second, the growth plate is fused, means skeletally mature. The lesion has started in the epiphysis, moved into the metaphysis. There is destruction here, and this appearance is described as soap bubble appearance. This is your giant cell tumor. Another X-ray, look at this. Lesion in the distal end of the radius, X-rays of the wrist, growth plate is fused, skeletally mature individual, lesion starting in the epiphysis, moving into the metaphysis. This is your giant cell tumor. Okay, are you able to work it up? Please do this. These are your classical images that will show up on your exam. Work it up again. X-ray of the wrist, skeletally mature individual. Lesion is in the epiphysis, moving into the metaphysis. Giant cell tumor. Skeletally mature. Distal end of the radius. Lesion in the epiphysis, moving into the metaphysis. Soap bubble appearance. This is your giant cell tumor, osteoclastoma. Okay, straightforward, simple. Now, what are the other MCQs that they will ask here? What do you see on the biopsy? You will see multinucleated osteoclast-like giant cells. Okay, so the tumor cells here are not giant cells. They are the mononuclear stromal cells. The stromal cells are the proliferative component of this tumor, not the giant cells. So what does it have? It has multinucleated osteoclast-like giant cells that are surrounded by mononuclear cells. The nuclei of these mononuclear cells are similar to the nuclei present in the osteoclastic-like giant cells. The proliferative component of the tumor are the stromal cells. We'll read more about this in pathology. And they stimulate, or they secrete rank ligands, which stimulates osteoclastic activity that causes the destruction. Less than 5% of the patients of osteoclastoma has a risk of malignant transformation and metastasizing to lungs. Now, what about the treatment of giant cell tumor? The treatment, remember, is the same as the treatment of aneurysmal bone cyst. As you proceed, you will realize that there are many similarities with aneurysmal bone cyst. The treatment here is extended curettage, where you excise, curette the base, and extend the curettage with liquid nitrogen, bone cement, or phenol to basically kill the residual cells. Okay, so remember, giant cell tumor and aneurysmal bone cyst, the treatment is the same. In fact, there are a lot of similarities between these two conditions. So to summarize giant cell tumor, a lot of people have this simple mnemonic, that is the E mnemonic, where they say everything is E for giant cell tumor. Starts in the epiphysis, occurs after epiphyseal fusion, is eccentric, is expansile, gives you eggshell crackling appearance clinically, and the treatment is extended curettage. So E for GCT. And remember, G for girls, more common in girls. So let's practice a few lesions so that you can be confident to mark the GCT on the exam. So look at this X-ray. What is it? It's an X-ray of the knee. Lesion is in the proximal tibia. Growth plate is fused, starting in the epiphysis, moving into the metaphysis. This is your giant cell tumor. Similarly here, X-ray of the knee. Lesion is in the distal femur. Growth plate is fused, starting in the epiphysis, moving into the metaphysis. Here, X-ray of the wrist. Growth plate is fused. Lesion in the epiphysis, moving into the metaphysis of the distal of the radius, GCT. Okay, right. Now the next thing we need to discuss is giant cell tumor variants. What are these giant cell tumor variants? These are tumors that have giant cell on biopsy. So it confuses the pathologist and they give you a diagnosis of giant cell tumor variants. Looks like a giant cell tumor, but it's not. So what are these? The list is this: non-ossifying fibroma, aneurysmal bone cyst, chondromyxoid fibroma, chondroblastoma, fibrous dysplasia, simple bone cyst, Brown's tumor, osteosarcoma, the telangiectatic type. All of them will have giant cell on their biopsy. It will confuse the pathologist, so they will give you a diagnosis of giant cell tumor variant. So what do you need to remember? The most common giant cell tumor variant is non-ossifying fibroma, And the tumor that has the closest resemblance to giant cell tumor is aneurysmal bone cyst. Please remember, the treatment is also the same, extended curettage. And if you pay attention, they almost look the same. So look at this now and tell me which is which. If you can answer this, then I'm confident you will be able to answer a lot of questions of the exam. So look at this X-ray. First, this is an X-ray of the knee. Growth plate is open, must be a child. Lesion is in the metaphysis because epiphysis and diaphysis are normal. Multiloculated, multiseptate, expansile lesions. What is this, friends? This is aneurysmal bone cyst. On the other hand, what is this? This is an X-ray of the wrist. Growth plate is fused, means after skeletal maturity. Lesion is in the epiphysis, moving into the metaphysis. Again, it looks similar. This is your giant cell tumor. Are you confident now? Are you confident differentiating GCT versus ABC? A lot of students send me messages getting confused about ABC versus GCT. If you follow these steps, you'll not be confused anymore. Look at the epi, meta and dia. Look at the skeletal maturity. Is the growth plate visible or not? Based on that, you can simply make the diagnosis. Okay? Now moving on to the miscellaneous tumor, the benign miscellaneous tumor, that was hemangioma. Hemangioma is a benign vascular tumor of the bone, most commonly occurring in the spine, can also occur in the skull and pelvis. Right? What is the problem here? The bone tissue is replaced by vascular tissue. Right? So bone tissue is replaced by vascular tissue. So how will it appear on X-ray? The bone is replaced by vascular elements. So it will show you long elements of trabecular bone like this. This has been described as vertical striations or jail bar or jailhouse sign. It's like jail bars. Bars in the jail, right? So jailhouse or jail bar sign. Also known as the striations of the spine. And this striations of the spine has also been described by radiologists as corduroy appearance. For people who don't know what corduroy is basically a material of cloth as shown here. So it has these striations in the material pattern, and this has been described as corduroy appearance of the spine seen in hemangioma. It's a benign vascular tumor occurring in the spine, usually asymptomatic. Now, if you take a CT scan, you can look at these striations from the top with the help of an axial view. And this gives you a representative finding known as this appearance. What is this appearance? It is called as polka dot appearance. Polka dot appearance. It's a design pattern. It is the same striations. If you look at it from top, it will give you polka dot appearance. What is the treatment? Usually conservative. The patients are asymptomatic. Very rarely they will come to you with pain. If they come to you with pain, you can either go for radiotherapy to ablate this hemangioma, or you can go for vertebroplasty, which is nothing but injecting the hemangioma with bone cement, right? So vertebroplasty, conservative management, or radiotherapy. That is all about your hemangioma, and those are the benign tumors that we discussed. Now moving on to the malignant tumors.